Museum made as a student who did many of the work with this proton activator, and she also had now like a side job where she makes movies or animations that are science related or muscle related, and she made this one for a proton activator. So I hope it works. Yeah, Mark, can you have the there should be a yeah.
NMLA is a neuromuscular disorder that results in muscle weakness. We investigate the origin of muscle weakness and test the ability of novel drugs to combat this weakness. But how does a healthy muscle work? If you want to use your arm, your brain commands your arm muscles to activate. This command initiates muscle contraction. Zooming into the muscle, you will see that it is composed of multiple tiny muscle fibers. These fibers are composed of little motors, which can contract. These little motors are essential for the generation of muscle force. Zooming into these motors, we will see that they are composed of two important components, actin and myosin. Actin and myosin behave like two magnets, which are highly attracted to each other and aim for interaction. To prevent continuous muscle contraction, at rest, actin and myosin are covered with a chain that blocks the emission force. This chain is called tropomyosin, literally myosin that can switch. But tropomyosin does not switch automatically. It needs to be initiated by a lever on tropomyosin, and this lever is called troponin. Troponin switches away tropomyosin in the presence of calcium. At rest, calcium is stored in the muscle. Only after a command from our brain to activate our muscles, calcium will be released into the muscle fibers to bind to troponin. Next, myosin switches away, which unblocks the binding spots on actin. Now that its binding spots on actin are exposed, myosin has to move towards actin, and that way the muscle contracts. In neuromyopathy, something goes wrong inside the muscle. Calcium is released, but the myosin does not fully switch away. And therefore, the myosin cannot properly attach to actin, which hampers muscle contraction. A novel drug that we are currently testing in our lab on isolated muscle fibers from neuromyopathy patients works as follows. The drug kindly glues calcium to troponin, which results in a higher number of tropomyosins that are switched away. Hence, with a similar command from our brain, more myosin heads can interact with actin, which results in more force generation. The drug is currently in a test phase, but we hope that it can improve the quality of life of neuromyopathy patients in the future.
Okay, so if I can recapitulate, I hope the sound was right up. If I can recapitulate it in one sentence, this is a compound. It's not yet available to use, but it's a compound that sensitizes troponin to calcium. So you will need less calcium, or at a similar calcium level, the muscle fiber will generate more force. So it directly acts on sarcomeric proteins. So we've been testing this on muscle fibers isolated from patient biopsies, and the question was, does this proton activator restore muscle function? And in this case, we started patients with a nectin-based neuromyopathy, because we know that they have reduced calcium sensitivity, as I showed before. And this is what we found. And this was also this was done together with LMBEX. Again, calcium over here, high calcium, low calcium. This is force. In black are control fibers. Dark blue are muscle fibers with patients with neuromyopathy called NET mutations. As we showed before, this is rightward shifted. That means that at a given calcium concentration, they will generate less force than control fibers. When you give this compound, I call it here CK, abbreviation from cytokinetics, this is shifted quite dramatically to the left, meaning that they might even perform better than control fibers, but the calcium sensitivity increases a lot. So that is quite promising. I have to emphasize here that this is a relative force. There are other mechanisms that can only calcium sensitivity that induce weakness, but the effect of changing calcium sensitivity are completely, I say that, counteracted by this compound. We also tested this in a mouse model. So this is a Netherlands-based Nebenheim mouse model, and it says in knockout that it's actually a deletion in exon 55. That was also discussed previously in this meeting. So these mice lack exon 55 in the Netherlands gene. Again, you can see here in red that when you give them calcium muscle fibers from these mice, they generate less force than the blue line in the normal, so-called wild type or normal mice. However, when you give this compound, CPA, this is just a number for this specific compound that they are testing, then you can see that the left shifted, and you can see that in this region, force, and this is absolute force, so this is not relative force, but this is really force that you need when you pick up a weight, or this is a very important parameter. You can see that is quite normal actually. And in yellow, I put this bar in, this yellow bar, because this demarcates the physiological calcium concentration. So when we are walking, or when we are, I don't know, picking up a bag or something like that, these are the calcium levels that are typically needed for movements like that. And at those calcium concentrations, the effect of this compound is quite pronounced. So I think this looks quite promising, at least in a tissue bed, because this is all done in vitro. So this is not done in all patients, but in muscle fibers in a tissue bed. So the next question is then, does it also work in vivo? And in vivo meaning in the whole body, when everything is intact and the drug needs to be delivered, etc. So we have not tested that in humans. Our group has not tested it in humans. I think Cytokinetics, this company, might be interested in that. I think that needs to be discussed with them. But there is another compound, or a drug actually, it's called levosimendan. And levosimendan is a registered drug that is also a calcium sensitizer. It looks a bit different than the troponin activator, but the basic mechanism is the same, but it acts on slow troponin C, slow troponin. So it works on the cardiac muscle, but some skeletal muscles also have slow troponin C in it. So it might also act on slow muscle fibers in patients. So what they did in this case, and these are all healthy subjects, it's not patient data, is, and please bear with me because it's quite a different technique that they use. So they had healthy subjects and they gave them 2 balloons, and they had to swallow these balloons. One would go into the stomach and one would stay in the esophagus. And then they stimulated the phrenic nerve. And the phrenic nerve is the nerve that innervates the diaphragm, the main respiratory muscle. And when you stimulate the phrenic nerve, the diaphragm will contract and will generate pressure that you can measure as a pressure difference between those 2 balloons. So they call that transdiaphragm pressure, PDI, transdiaphragm pressure. So normally that's maybe about 120 centimeters of water. Centimeters of water as a unit that we use for that. And at the same time we measure EMG signal. So the electrical signal of the diaphragm, or the neural impulse that goes into the diaphragm to generate this force. So they asked the patients, they gave them a monitor and they said, okay, now you are required to generate 40% of your maximum transdiaphragm pressure. So they breathed, they inhaled, they saw on the monitor that they reached 40% of the maximum. They said, okay, maintain this level. And at the same time, they measured the EMG activity that was required to generate that force. They did that here in black before study medication and in blue after study medication. But in this case, they received a placebo. So there was no effect. You can see in both cases they had similar force and they had similar output from that EMG signal. So they need the same neural input in the phrenic nerve. But then they use this levosimendan, which is a calcium sensitizer that acts on troponin in the muscle fibers. And then they found this result. So again, they had visual feedback. They said generate 40% of your maximum diaphragm force. That was this level again, about 60 centimeters of water. And they did that before and after the study medications, and the same in both cases. Force was the same. So look at this. The EMG signal that was required to generate the same level of force was much less when they were infused with levosimendan, which is this calcium sensitizer. So this means, and it's actually also what you would expect actually, they require less neural input to generate the same force when they have this drug. in the muscle fibers. And that's important because that means that they will have less electrical signal, they will have less calcium cycling, they will have less ATP that needs to be generated to initiate this muscle contraction. So this should definitely, they should definitely reduce muscle fatigue, also in the respiratory, especially in this case in the respiratory muscles. So I think that tests like this, and to be honest, I doubt if this is applicable to healthy patients, because I wonder whether this, well, they show that it works in diaphragms and healthy subjects, but it might also affect cardiac function, and maybe that's something that's an undesired side effect. These troponin activators, I think, are more pure. They only act on fast twitch muscle fibers. They will not affect the heart, and they might be promising for the future. So they call it neuromechanical coupling. So the coupling between the neural input and the mechanical output is improved. So for the same neural input, you get more mechanical output. Okay, so we are testing this now not in patients yet, but in 4 mouse models of myelopathy. We do this in a consortium. Siegfried is also quite involved in this. We group in Italy, we group in Germany, and we are testing these 4 mouse models. We're looking at protein analysis. We're going to give them troponin activators and see if their in vitro function improves and how that also correlates with changes in the muscle fibers. And one of the things that we're going to focus on are the respiratory muscles. Because respiratory failure or respiratory insufficiency is an important clinical aspect in patients with myelopathy. We want to see if this improves respiratory muscle fatigue parameters like that. So this takes me to my almost my last slide. Maybe a thought for the future is I've been looking into the literature, and I think that hardly anything known about real respiratory muscle function in patients with myelopathy. I really did my best. I did a top net search. Hardly anything is known. I think that is caused by the fact that measuring respiratory muscle function is very difficult. But I think it's clinically very relevant, especially for patients with a primary muscle disease. So maybe that's something for the future to consider to get involved in, also for ARDS. Because I think it might give you also outcome parameters that you need to see if therapy is efficient. And that does not necessarily have to be, you can use these balloons, that's a bit invasive, but I've never tested it myself, but this clinician that I work with has done it himself, and he's talked to many patients he's an ICU physician, he did this in many patients, and it's well tolerated. It's not a nice sensation, but it's well tolerated. But you can also use echo, for instance, or MRI. I think Carsten Boelman is now using, I don't know if he's here yet, but he's using MRI to measure in vivo diaphragm function. But you can also use echo. Non-invasive, you just put the echo probe on your diaphragm. Nowadays you have these special features they call speckle tracking, and you can measure with high reproducibility, you can measure a contractility of the respiratory muscle, the diaphragm in this case, and see how that contracts and maybe if that improves. If it is less invasive than myelopathy, if it improves after you tested a therapy. Same for EMG. How does a neural input change when you have changes in when you have tested it in a compound? Okay, so I've talked enough. I would like to thank all these people, and I'm sure there are many more who have been involved in the studies, working together on protein analysis, on providing muscle biopsies, characterizing muscle biopsies, and many of these people are here. But I just want to emphasize it's a group effort, and also the data that I've been showing. I've only showed data from my lab, but there are also other labs that have done similar measurements, and they basically find similar findings. And obviously, all patients were made available biopsy, because without biopsies, we cannot do this study. So, thank you very much. Okay.
Okay, right now we're going to take about a 10-minute break. We didn't have time for a lot of questions, so I would encourage you to ask some questions in the break that you have, and then we'll come back with the kid panel. And then kid panel. Okay, we'll see you in about 10 minutes. 10 to 12 minutes. Yeah, let's get the kiddos in here. Let's empower them.
Very interesting.
Did it come across?
Yeah, so psychokinetics.
Cytokinetics.
Cytokinetics. And I think on their site they have that really cool simulation.
Yeah.
So they have these drugs that will blood muscle calcium, and they were developed for use throughout different muscles. And so your thought is like, let's try to use these because I can boil it down.
Oh, that's right,
I'm a
yeah.
layperson.
So they have, on the website, they have.
I've seen the names of KC or whatever. Yeah. Okay.
Well, they're testing it, they have like
I looked on one of their investor slides had on them like a long time ago.
Yeah.
Presentation, so I've been every once in a while I go back.
well, we had this meeting at one point. Mark,
He was probably
he was there. And then Jasper, who then works so they know about AFVS and
It's your son's up, right?
okay. And then so they I know they're interested, but what they're looking for is like AFVS man. I think they need
About psychokinetics.
this company. They need a strong outcome parameter. I think they've tested ALS patients with their
Right.
I think this is the best. You're right. It's very hard to, you don't know how fast they go down, and so it's really certain subtypes are, yeah, so I wouldn't know how to contact them, but maybe yes.
Oh yeah. Hey, Mark, before I'm sure we're gonna have a brief call.
I think if you're organized and you have outcome parameters, you have an organized patient group, I think they might be interested.
Okay. Thanks. Thank
Yeah,
you
sure.
very much.
Sonia, were you looking for me for anything?
So normally, so let's say this one, and then this is 1 micrometer. This. And then stop. This will be never fully reaches to here, or if not then because it does not know when to stop and it's supposed to stop. You mean if that would be a solution? Yes, I think that muscle can work with the probably has a minimum but I'm quite positive that there's only 70% of the strength you can have relatively normal. So is that a question? Yeah, so I was wondering if this yeah. So how would you encourage yeah, that's a good question. I think if you let me draw it. So let's say this is negative. If you zoom in on negative, there's a lot of repeating structures. So this part is almost the same as this part. Let's say you have mutation here. Yeah, let's say you maybe figure out so in the end you will have some of these things, but the piece that has mutation, that repeating structure has mutation is gone, and then you will have a filament that is so it will go like this. We'll stop here. So it will lack this distance, the muscle can lift without it. So that could be an interesting. We don't know. therapy maybe, but that needs to be designed and tested, and you need to be able to take this piece out. This is maybe also a discussion for cancer, if that's possible. But it's something.
No, you're talking about something different.
Oh.
I was talking about, let's say, the patients or assays. Patients are really patient, standard ones, and so we have to show.
Yeah.
We found a way to just enhance the imaging power.
Oh. Okay. Yeah. Probably this happens already. So it's a very good question. So we studied this in mice. This is very hard to study in humans. So we studied this in mice. So what we did is, so we had this mouse that has a magnet action, so they have magnetic test. And then we had a muscle, like this. So a whole muscle. We took muscle fibers, and we looked at the criminal life, and that was reduced. But then we also had the muscle fibers. So this is a normal muscle, and this is a muscle fiber. We took out a muscle fiber from here, and here, and we measured how many of these soft muscles. And guess what? There are more. So this happens. It's like as if the muscle wants to adapt. And so maybe helping the muscle, we don't know if it's enough. We don't know if this happens in humans, because in humans it's hard to need to have a whole muscle fiber. But it would be interesting to find other ways to measure this point, see if that's enough, if you can promote that. Yeah. Because these mice, they can live with these short they survive. And then they die, and actually some mice just survive until they stay. So it would be interesting to see if humans also that. I just talked to Klaus and Bonneman to see if they find a way to study that. See the length and softness of the muscle. It's a good question. So you have a work as well? Does he have a, is he here? How's he doing? Yeah? Is he do you know which mutation?
Which NEP mutation?
What kind of mutation? Yeah. Is this him?
Yeah, that's it.
He's very active.
I don't know exactly. I have the report, but
No, I'm just
yeah, thank you. Another question that I'm not sure that tell me if it's in your field. So this is a bit radical, but so we have some I'm skeptical that we have done this. A lot of the kids, right so we don't need to do
well, that's something that seems to the back work. No, maybe not. Maybe you. I don't know if this is really your question, but he has been trying to make a mini for cardiac muscle. Cardiac muscle, heart muscle also has an element, but it's much shorter. Nevertheless, they have component legs that are almost similar to skeletal muscles. So he's been trying to express in mice a cardiac, but it has been very difficult. Maybe you should test it. And in that sense, yeah, you are right. Maybe you can use this other protein, cardiac protein, to see if that in the end has enough. That's something that we've been working on. Thank you. Good questions, yeah. So good luck.
No. We gotta record that stuff.
Yeah. I was probably had a lot
This is a tripod, the camera's just here. It's like a stand. Kind of like a microphone stand. Instead of my camera's right now. It doesn't really do anything. Oh wow, they're really cool.
All right, I'm gonna come and help you. I'm gonna plot a chair.
Okay, we'll get this going soon. We're gonna get the kiddos in here and get started.
You want to do a face paint?
Marlene, I can.
Yeah. We're not doing the stage. But I think no, the stage is not close to you. You know what's gonna happen?
Okay, we're gonna start a child panel soon, so let's start to get the kiddos that are in the child panel up here. Do we know who those are?
And remember, Marlene, you can pass on any question.
So that would be Greta, Ellery, Vilma, and Kate Mitchell. Okay, we'll get those people organized. Oh, Laura, she's already up here. If you're looking for her.
Wilma, you want to take my girl?
Laura.
You're not right.
Laura, she's already in here.
Kate, do you want to?
Oh, you're getting Ellery. Okay, sorry. Kate, do you want me to transfer you?
Marlene, did you want to sit with Katie and Wilma?
Okay, I'll transfer you.
We have Ellery.
Laura, when you go get Ellery. I'll transfer you, sweetie.
Oh, do you want to do it in a chair?
That's fine. I got
You know what, Patty, maybe can Kate come and then Ellery can come up here and her chair, that might be easier for her. Is that okay?
Hi, Kate.
Oh, you're right. And then it's up to the parents might have Yes, please. Well, honey, you know, you and Katie, why don't you might each share the, let's do this. You and Katie, you're gonna share the board. Wilma can have this one.
Yeah,
And then you and Katie will share the board. You got it.
Sorry, I didn't get you. Yeah, Justin will tell you, he's in charge. Axel. They were
So whenever you're done talking,
I mean, even just to speak.
Can I get a picture of you and Axel and all the kids?
do you want to switch with Wilma then? Why don't we switch places with Wilma and her keys?
If she switches with Wilma, will they picture? If you were ever
Be ready to speak after the school secretary.
gonna help. You know, we'll, I think maybe we can cut into a little. Okay, hey, can I get you on one side and Patty on the other?
Yeah.
Oh, sorry, I told my husband. All right, everybody.
Sorry.
So the first time we're gonna do like good, like regular smile photos, and the second time we're gonna do crazy things, right? Ellery.
I guess I wasn't thinking Are we gonna photo lunch? Yes. Okay, now ready.
Okay, on 3, we're gonna do pretty faces. Okay, and now we're gonna be. Awesome.
All right. All right, you guys ready? No, but you know what, Ellery? Oh, yeah, just in it. Actually, there we go. Yeah, that's perfect. All right. Hey, our door.
Actually, we don't need this on, do we? I'm gonna turn it off so it's not shining in your face. Hey. Oh, you don't have your microphone now. We got that one. Okay. All right.
I do have a good camera. You know what I want to do? Kirby's gonna let all the doors, and she's gonna have black. I'm doing glasses.
Okay, welcome to the Kids Club. We're going to do some introductions. We're going to start off with Ellery. Just say where you're from.
Hi, my name is Marlena. I'm from Pennsylvania in Chester, and I'm 8. Hi, my name is Greta, and I'm from Manhattan, and I'm 8. Hello, my name is Linda.
So this is Wilma, she's from Sweden, she's turning 7.
Hi, I am from Monroe, Illinois, and I'm 10.
Start off with the first question. What is your favorite activity to do with friends?
I like to play. Tag. And hide and seek. Different games. Like different games. At school they have Uno. School they have Uno. That's for Uno recess, so it's for Uno. In their recess, they play Uno. I like to play with my friends at recess, like usually me and 2 or 3 of my friends usually not so long at recess. It's really fun. I like to do that. I always love to play tag because I also like to play piano too. And sometimes I also like to go out and have some play with my friends.
Likes to play tag. Like to dance. That's it.
Me and my friends, we like to make up games and play out outside and like, we had it on the and something.
What are your favorite things to do in therapy?
I like to lecture. I like to play games. On the light and stuff like that. Chapters connect to don't break the ice. I like to know Nintendo, and once I finish all my things on therapy, my physical therapist lets me sit on the Wii Fit board. It's really fun. For my PT, he can make like magazines, and so he had me like work on sand and all of that. And then I modeled. So he might have saw that on Facebook.
Yeah.
And I did this in a video. He puts it on the magazine. And I was really like doing that. And then in OT, I had to go on the slide. It's fun.
She likes to swing from Tarzan swing. She likes that. Horseback riding. You don't know that. Yeah, she likes horseback riding too. How do you explain NN to other kids?
I say that my muscles aren't as strong as yours are.
Neuromyopathy is very serious. What I have is my muscles are weaker than other people's. And I think that's it. So when I was playing, and I think I might experience it. It feels like scary. I don't know why, but it's so bad. Scary.
So she says she's get tired in her legs, and she gets tired, more tired than the other kids when she's playing and needs to rest. And she's also talking about she's not running as fast as the other kids. So that's how she explained to her friends